As we discussed in the previous episodes of Endocast, we discussed about the endodontic microsurgeries, indication, contraindication, and the procedures. Um, Today, we are going to discuss about the outcomes of endodontic microsurgery. So, ladies and gentlemen, welcome to the 10th episode of Endocast, hosted by Francesca Cirutti. Hi, Francesca.
Hi Ahmed, and of course by Ahmed Shauki.
Yeah, of course. So, when we are talking about the outcomes of endodontic microsurgery, it's really difficult to just search for evidence about that because most of the papers and literature include other procedures like intentional replantation, like perforation repairs, like incision and drainage. So there are a lot of heterogeneous data. So it is difficult to just separate the outcomes of just endodontic microsurgery to give some sound percentages about the success and failure. So what do you think about that, Francesca?
Well, I found a recent systematic review of the literature that considered 26 articles, and about that, they were extremely precise in discriminating the data relative to each procedure. And so we can see that about periodicular surgery, the healing of the cases they treated was ranging between 59 and 94%. While if we consider only the survival of the tooth, so the tooth is in function without complete restitutio ad integrum, we find that the success rate are between 79 and 100% of the cases. And they also consider some other procedure that you mentioned before. So the intentional replantation, for example, and in this case they obviously only consider the tooth survival over 2 years, was between 88 and 89%. So it can be a great tool in our hands when there is no chance, for example, to do an endodontic microsurgery procedure. And also they consider the root resection, which is maybe a little bit old-fashioned as a procedure but still working, in a percentage between 38 and 100% of cases. So it's probably extremely dependent on who performs the procedure. And we have no strong evidence, as we can see many systematic reviews with meta-analysis, because the quality and the number of the present studies are not enough to have a strong evidence about anything. So what do you think?
I have been looking on the this recent paper from the International Endodontic Journal about the factors that influence the outcome, and it was really interesting about the format they used, the PICOT format, and they mentioned that the most critical outcomes is about the healing of the lesion, which is a loose criteria. But if we use a strict criteria for evaluating the outcomes, we would like to see healing of the periodontal ligament around the whole root, of course, after resolution of the lesion. But also, the most important factor that I have healing, periodontal regeneration, cortical bone regeneration, and tooth survival. And uh, if we're talking from a clinician perspective, we would like to highlight that we need the outcome of restoration of the periodontal ligament around the root and resolution of the inflammation. So the ideal healing, in summary, would be lesion reduction, no inflammation, periodontal regeneration, cortical bone regeneration, and of course, functional tooth survival. So, one important question that is always asked by our colleagues: till when I follow up the cases after endodontic microsurgery, and also when to expect healing. I'm talking about the time here.
Well, that's an interesting question, because we can see that the percentages of healed cases can extremely change between 6 and 12 months of observation, for example, because we see that 51% of cases is healed at the first follow-up at 6 months, but then at 1 year we can see percentages rise up to 70%. But we have to say that between 24 to 48 months is the moment in which we can see the higher percentage of healed cases, because we are 75, 76%. But then, if we observe for a longer time, our percentages of healing can actually decrease. So our success rate can decrease. And this is probably why we can have a relevant amount of late failures of our therapies. And the reasons for these late failure can be extremely different. We can have reasons that are not related to what we did, for example, the fracture of the tooth or a restorative or periodontal failure. But on the other hand, we can also have problems related, for example, to the capacity of our retrofilling materials to keep the seal. And so we can observe also late failures 5 to 10 years later, even 15 or 20 if we have the opportunity. But it's no strange thing to see that over time, in a long observation period, the failure rate can increase.
I agree with you about that, and I can say that we have to think about failures after 10 years, for example, or 15 years, because shall we call it a failure at that time or not? Because this is a controversial issue, because we have the tooth survival for 10 years, for example, or 15 years, and then we start to show some signs of failure. So I guess it's a good job to retain the tooth for 15 years.
Yeah, I completely agree. I think that we have to make peace with the fact that what we do is not forever. We are just buying time for our patient and delaying the extraction, for example.
Yeah, that's for sure.
And what about the techniques? What did you find in the literature?
Well, if we look into literature up to 2021, we can find that the technique can impact the success rate up to 69% success in endodontic microsurgery. But also in the recent years, I'm talking about the from 2020 to 2024, the last 4 years, we found also that the results is favorable and success increase up to 76%. This might be due to the introduction of modern techniques. And if we look into those modern techniques per se, like the use of a microscope, ultrasonics, all the recent material introduced into the field of endodontic microsurgery for retro cavities, we can find that there is an increase up to 92%. So, in my opinion, the modern techniques or the technique of the surgery really impacts the success rate of this procedure. So, just want to ask you a question because we discussed a lot of things from literature. Why won't we summarize now the factors affecting the outcome so that our colleagues just know uh, uh, as a list which factors have a significant effect on the outcome of endodontic microsurgery?
Okay, well, we can start from the patient because, for example, we saw that the age and the sex of the patient do not have any kind of impact on the outcome of the endodontic microsurgery procedures. On the other hand, about the health of the patient, well, it's controversial because obviously we are not doing this procedure on certain types of patients. And so the only thing that's relevant in the literature is that if the patient is smoking, probably is going to have a negative effect on the healing of the soft tissues, and so it can have some negative effect on the outcomes. But this is the only thing that was found evident in this moment. What about the teeth? The anterior and maxillary teeth seem to have a higher percentage of success, with respect to posterior and mandibular. And this is probably due to the access, which is easier in anterior maxillary teeth. But the anterior, lateral incisor in the maxilla are related to a lot of failures. But this is probably due to the fact that most of the times there is the chance of these teeth to develop a scar due to dedations, due to the fact of the root is extremely curved, etc. So there is a higher probability of these teeth of having a scar, and in an aesthetic area we know that can be a problem. And also, last but not least, another problem that can lead to a failure of our procedure is when we treat teeth with an isthmus between two canals. And this can be a problem because we can over prepare the isthmus, and so we can just have some perforation or some crack if we just don't follow the right inclination of our ultrasonic tip. And also because obviously these areas are more difficult to clean, and so we might lose something, and so we just might fail in treating some of the anatomy of the root, and this also can lead to a negative outcome of the therapy. What about the lesions?
Yeah, this is very important factor actually, because we have many things we talk about the lesion. So the first thing is the signs of inflammation at the time of the surgery. So if we have that signs of inflammation as we do the surgery, so we might have a negative impact on the outcome and healing. The second thing about the lesion is the preoperative size of the bony crypt. I mean the size of the lesion. So as long as we have a larger lesion, we have a possibility of decrease in the outcome of the microsurgery, maybe probably due to the large size of the lesion and inability to clean and reach the whole area of the bony crypt. So also we have to address that when we think about the outcomes. Another thing is the sinus tract, the presence of a sinus tract. What's really make things difficult during flap elevation is the presence of a sinus tract, because it is attached to the soft tissue, so it may complicate the flap elevation, and this also might lead to some difficulties during surgeries. And after flap elevation, we might see that we have adhesions in the bone, and this results in the so-called apicomarginal defects that will also might affect the outcome of endodontic microsurgery. Sometimes these cases can be managed with collagen membrane. We put a membrane, and sometimes this is an indication for that, but there is no significant impact of using the membrane or not using the membrane. So sinus tract is one of the factors that really affect the outcome of endodontic microsurgery. So, Francesca, what about the another thing in the tooth itself, the quality of the coronal seal?
Oh, the quality of coronal seal is of paramount importance because I think that when we choose to do endodontic microsurgery on a tooth, is that because there is actually an adequate coronal seal. So it's like a prerequisite. If I don't have an adequate coronal seal, I have to provide it and then do the endodontic microsurgery. Otherwise, there is no sense in trying to seal from the back when from the coronal part of the tooth there is leakage. And so this is obviously a thing that is going to affect massively the outcome of our therapy. And also another thing, the presence of posts, because first of all, when there is a post, for us it's more difficult to plan our surgery because we have to consider the length of the post and we have to have the space to provide an adequate filling, and sometimes with a post it's not easy at all. And also because when we do our preparation with ultrasonics, we risk to generate some microdecementation of the post, we risk to promote coronal leakage from the post, And so this is associated with a significantly lower heal rate in our cases. So posts are always tricky. But I think there is something else. There is something else because sometimes one surgery can fail. And it can fail because most of the time we do something wrong in the procedure, and so maybe we miss some anatomy. We don't treat an isthmus, we don't treat a lateral canal. And the thing is, if we are able to find out what is the cause for the failure of the first surgery and we address it in the second, then it's like we were doing it for the first time. And we have the same percentage of success than when it's a primary endodontic microsurgery. So this can be good for us. But the thing is, you have to be able to understand the reason for the failure in the first place. And so it's a thing to consider, maybe with some experience. And what about magnification and illumination, microscope fans all over the world?
Yes, microscope. So everybody should have a microscope before doing endo. Actually, yes, magnification is very important. As we know, we cannot treat what we cannot see. But the strange thing that until now there is no evidence about the impact of using magnification in endodontic microsurgery. So it's called endodontic microsurgery, but there is no impact in literature. But let me say that I really can do, and many of us, and already many of us has done this, about doing an apical surgery in the anterior maxillary teeth without a microscope. This can be okay, but if we ask ourselves, can we do that in a molar surgery without a microscope, without high magnification illumination? I think this would lead to a significant decrease in the success of the procedure, because we cannot see the anatomy, we cannot see the roots, we cannot conveniently remove the lesion. So, in my opinion, maybe in literature there is no evidence of significant impact, but as a clinician, I believe it has a very strong impact on the success of the procedure. I hope you agree with me about
I
that.
agree 100%. I would not even start. Yeah, I can dare doing
Exactly.
it in an incisor, maybe, yes, but on premolars or molars, no way. No way.
Exactly. So the next thing is about the preparation, the retro preparation. We have a lot of old and new methods for doing the preparation. So what do you think about that? If there is a difference?
Well, even in this case, I think the literature is messing with our heads because on one side they tell us that modern techniques lead to a significant improvement and to a significant increase in the success rate, but on the other hand, there is no strong evidence. So you find some articles that say that if you do a 3 millimeter preparation with ultrasonic tips and then you're able to fill it with maybe bioceramic materials or MTA or IRM, whatever, you're going to increase significantly your percentage of success. But on the other hand, you find 2 or 3 articles that say that it doesn't count. There is no sign of improvement if you do 2 or 3 millimeters or 1 millimeter retro seal, and it's not even relevant the amount of sound dentin that you have all around your prepared root canal, because we knew from previous articles it was supposed to be 1 millimeter, but other articles they say it does not count. So even in this case, unfortunately, the literature cannot help us with strong evidence about what we say. And this is a pity, I think. But what about the procedure itself? What do you think can just change the game?
Yeah, I will not say change the game. It can screw up the whole procedure if you do a major error. So here we're talking about doing a major error like damaging the root, wrong preparations, maybe missing the anatomy, maybe improper sealing of the cavity, this all can just put the procedure into a very low success rate or even failure. So we need to just make sure that our procedure is technically sound, like in going into the bone, like detection of the root, like detection of anatomy, like preparation, our cut of the root apex. Everything should be well done in order to reach a high success in that procedure. And by the way, the rate of success of endodontic microsurgery is far higher than the non-surgical retreatment if we compare to it. So the errors is the only thing that can put it to zero. And last but not least, and I would like to ask you about this question. Do you find a surgeon, an oral surgeon, is better or an endodontist to do the apical microsurgery?
Well, once in a while, the literature can tell us that endodontists do it better. But why? Because the reason is mainly in the knowledge of the anatomy. Because as an endodontist, I exactly know what I'm looking for. I go looking for isthmuses, I go looking for extra canals, I go looking for all that anatomic variabilities that can just impair my results as an orthogonal treatment. And so this is the reason why endodontists have higher success rates than oral surgeons. And also because if you look at the techniques, many times oral surgeons, they just cut the apex, remove the lesion and close. So they don't put a retrofilling. On the other hand, we are doing an endodontic therapy. So we shape, clean, fill the root canal. We do the whole thing. And this is probably why we get higher results once in a while.
I totally agree with you. I totally agree.
Of course, I mean. But guys, I know it was long, but it was a bit difficult for us to summarize all of the aspects that can have an influence on the outcome of endodontic microsurgery. We hope you enjoyed it. And so thank you for watching. Thank you, Ahmed, once again.
Thank you. Yeah. So stay tuned for the next episode of Endocast with Francesca Cerutti.
And Ahmed Shauki. Bye.
Bye.
Bye.